cytoplasm. Okay, yang atrophic variant pula dia ada a lot of, kenapa dia atrophic? Sebab dia ada banyak fibrosis and dia punya lymphoid follicle dia kurang lah sebab dia dah kecut dia banyak fibrosis. That's decreased lymphoid infiltrate. Okay, that's Hashimoto, the autoimmune. Remember, female ramai 10 to 20 over in females and only one male. Okay, and there is risk of developing into lymphoma and also carcinoma. Okay, next we go to granulomatous decurvain or subacute granulomatous thyroiditis. Kita nama orang lah. Okay, so here dia nampak granuloma pula. From the name you know lah, dalam ni ada banyak granuloma. Granuloma macam juga dalam TB You see a lot of macrophages with a lot of giant multinucleated giant cells. Tapi kalau TB dia macam U-shape kan, nucleus kan, the right hand kan. Tapi kat sini dia banyak foreign body type of giant cells yang nucleus dia bersepang ni, dia punya nucleus dalam the cytoplasm. So in granulomatous thyroiditis is less common than Hashimoto. Okay? Cause don't know. Could be viral due to mumps, measles, influenza. 20 to 50 decades of life. Jadi female-male ratio only 3 to 1 as compared to Hashimoto dari 20. But it has strong association with HLA B35. In decurvain dia painful. Hashimoto tak painful. Okay, they have fever, they have painful tender enlargement of the thyroid. It can be unilateral or bilateral. It's hyperthyroidism with extensive destruction. Because of the extensive destruction, you tak boleh nak produce the thyroid hormone. So you get hypothyroidism after that. Okay, then you see marked goiter, very subtle, tak nampak sangat goiter dia, the enlargement of the thyroid, or there can be marked goiter with adherent to the surrounding structure. Okay, dia macam melekat the goiter tu melekat dekat dia punya neck can cause obstruction juga. So microscopically you see patchy changes and different stages found at the same gland. You can have a lot of neutrophils, abscesses nanah dalam the thyroid gland. Macrophages in the late stage you see macrophages, giant cells, apa lagi, damaged follicles, and then later they have fibrosis. Sebab tu dia melekat sebab dia ada fibrosis. Okay. Riddle. Yang ni pun melekat juga because of the fibrosis. Kat sini is riddle thyroiditis is rare disorder in adults and elderly, also female. Remember thyroid, female. Okay, densely fibrotic inflammatory response process of thyroid, and dia melekat dekat thyroid tissue, dia macam form a collar, macam neck collar, dia melekat like that. That's riddle thyroiditis. Clinically ill-defined thyroid enlargement with profound dyspnea because of this, the adherent to the neck. It causes difficulty in breathing or dyspnea. Grossly and extremely firm tissue binding the soft tissue of the neck. Dia macam orang pakai collar, it's like an iron collar the neck because of the complete obliteration of thyroid gland with replacement by fibrosis. The fibrous tissue completely replaces the area of gland involved, and there is also lymphocytes and histiocytes inside the thyroid tissue, and dense fibrosis tract extend beyond the thyroid capsule into the adjacent muscle. That's why dia melekat sebab dia fibrosis tu akan terus infiltrate into the muscle behind around the thyroid gland, and it requires surgical intervention to release the adhesion tu. Okay, and bila dia ada adhesion macam tu dia melekat-lekat, you kena exclude cancer. Because kerana cancer kan dia suka infiltrate kan. So you have to differentiate. Ni riddle thyroiditis ke cancer, and that can be determined by using looking under the microscope lah. Akan hantar the thyroid gland tu dah buang semua, send to us. We pathologists will look under the microscope and determine the diagnosis. Is this riddles or is this cancer? Go into cancer with this. So riddles dia banyak inflammation, dia banyak fibrosis in between. This is riddle thyroiditis. Tapi dia tak ada giant cell macam tadi. Yang tadi sebelum ni decurvain tadi banyak multinucleated giant cells kan. Alright, this is I won't go into detail, so just for to help you all differentiate between Hashimoto, subacute, granulomatous and riddles Ini semua kita dah bincang just now, baca je. Okay, Graves Graves ni banyak discussed by biochem. In Graves' disease, dia diffuse it's like macam diffuse enlargement of the thyroid gland, and in Graves there is hyperthyroidism. Sebab apa? Because of the hyperplasia of the thyroid gland or the thyroid follicular cells. And dia ada juga infiltrative ophthalmopathy and infiltrative dermopathy. Again, female, 10 to 1. Peak incidence young, 20 to 40. Selalunya dia datang with apa? Symptoms of ni, hyperthyroidism, tremor, sweating, apa lagi? Weight loss lagi, mata terjojol kan? Because of that ophthalmopathy tadi. What do you call that? Apa dia? What do you call that? Proptosis, right? Proptosis, okay? And another name for Graves' disease is also known as toxic goiter, because dia dah toxic sangat, banyak sangat dia punya thyroid hormone because of the high T3 and T4. So there'll be low TSH in the negative compensatory mechanism kan. If the T3 T4 high, TSH will be low. And it's also associated with HLA, B8 and DR3 in Y. It's autoimmune, sama macam Hashimoto juga. It is autoimmune, initiated by immunoglobulin antibody against specific domains of TSH receptor. So this IgG ni akan act on the TSH receptor. So TSH will be a lot, and then dia akan increase production of T3 and T4. That's why they are hyperthyroid in Graves' disease. But microscopically, you see hyperplasia. It forms like papillary formation macam ni, and you see this scalloping. Nampak tak yang putih-putih tu? Macam scallop dekat luar thyroid epithelium tu, thyroid follicular cells tu. That's what we call scalloping. Ni pun favorite MCQ questions. What are the microscopic feature of Graves' disease? The papillary formation with scalloping of the colloid. Yang pink-pink ni is colloid. Tiba-tiba dekat sini dia ada lubang-lubang kan? That is what we call scalloping of the colloid. With hyperplasia of the thyroid follicular epithelium. Then you can see the papillomatous structures with scalloping of the colloid. Okay, so grossly you see diffuse enlargement of the thyroid gland. The capsule is intact. It's not adherent. Tak adherent macam riddles tadi. It's a meaty appearance. Bila you potong dia macam thyroid gland tu macam daging tau. Bila you potong daging, dia macam tu colour dia. Red, meaty appearance. And pre-op iodine causes colloid accumulation and devascularization. And biasanya before operation, you nak kecilkan dia sikit, you bagi iodine to cause devascularization and also gland involution so that it's not very vascular, so that there's reduced risk of bleeding during surgery. Okay, and histologically there's tall columnar epithelial cells, hypoplastic pseudoepithelial buds, no ATP of the cells. Maknanya the nucleus tak ada ATP, tak ada nuclear enlargement, tak ada nuclear hyperchromatism, tak ada nuclear pleomorphism. That is what we call ATP, no ATP. Okay. And the colloid is diminished. Colloid dia macam kena makan. That's why dia ada scalloping. Sebab colloid dia being used up to make up the T3 and T4. Okay. And there can be also lymphoid follicles. Tapi sikit-sikit je lah. Dia tak macam banyak macam Hashimoto tadi. You see diffuse lymphoid follicles in the thyroid gland. Tapi in Graves, you can see a few, tapi not that many as in Hashimoto punya lymphoid follicles. And there is extraocular muscle and tissue edema, increased deposits of mucopolysaccharides, and also fibrosis and lymphocytic infiltrate. Mucopolysaccharides ni also duduk kat belakang mata. That's why dia akan push the mata terjojol ke depan. Dia jadi proptosis. Okay, or ophthalmoplegia juga. Okay. Alright. So what's the danger of Graves? Is the thyroid storm. Apa jadi masa thyroid storm? The severe hyperthyroidism, and this is a medical emergency. Kena treat cepat. Kalau patient boleh mati. So much of T3 and 4, so that can cause birth, can cause cardiac arrhythmia. Okay, and it occurs most commonly in patients with Graves' disease due to elevation in catecholamines, such as ada benda aggravator lah yang precipitate, such as infection ke, surgery ke. You stop the anti-thyroid medication, then tiba-tiba the T3 and T4 shot up, and then there will also be elevation in the catecholamines, and then there's fever, there's tachycardia, and they can die of cardiac arrhythmia. Okay, that is thyroid storm. Okay, now we go to goiter. Goiter is benign. It's not cancer. It's not a tumor. It's just this hyperplasia of the thyroid follicular cells. It's very common. Kadang-kadang you tengok pergi pasar ke, nampak orang tu besar dia punya neck kan, that is a goiter. Tapi it doesn't cause problem. Tapi a large one can cause shortness of breath. It can cause difficulty in swallowing, a giant multinodular goiter. So in diffuse multinodular goiter, there is diffuse or nodular enlargement. Nodular means dia punya surface tu macam berlekuk-lekuk, dia nodule kan. Kita tengok orang tu punya neck pun dia macam naik turun it's nodular. It's grossly visible mass or nodule in 10% of thyroid glands at autopsy, but microscopic irregularity is present in about 40%. Okay, yang ni 3 to 5% can develop cancer. Okay, so a goiter, kalau dia dah teruk sangat besar, it cause problem, it has to be removed, and it also has about 5% of developing cancer. Predominantly the follicular variant of papillary thyroid carcinoma. Selalunya kalau kanser mana? Kanser yang bernama papillary carcinoma. Okay, and up to 17.5% with papillary microcarcinoma. Okay, diffuse goiter ni also named simple goiter or colloid goiter. Sama je, diffuse, simple, colloid. Simple ni maknanya dia tak nodular. Kalau dia banyak nodule, we call it multinodular. Diffuse is in early childhood, it peaks about puberty. Female again is more than males. And there are two types. Satu endemic goiter, satu lagi sporadic goiter. Endemic ni bila banyak population dia yang ada benda tu. It's more than 10% of the population. That's why we call it endemic. Tapi kan kat mana? Kat mana yang tak cukup iodine? Yang duduk kat gunung kan? Kat Mongolia ke apa, dia tak makan seafood. They are far from the sea, and they don't have enough seafood, and have enough iodine. And then there will be hyperplasia, trying to produce more T3 and T4. Endemic, more than 10% population, that's deficient in iodine intake. Okay, iodine you can get from the soil, the water, the food supply. Okay, and goitrogens, dimakan sayur-sayur yang goitrogens. Apa dia sayur yang called goitrogens? It can cause goiter. Cabbage are goitrogens. It can cause goiter. Okay, there are other foods. And another type of goiter is the sporadic type of goiter. Okay, sporadic, they just occur like one in the blue, dalam maybe 100,000 population seorang, they just macam sporadic macam tu. There is minimal iodine, like coupled with increased demands and dietary goitrogens. Dia makan dietary goitrogens lah. Hereditary biosynthetic defects, there's also biosynthetic defects in thyroid hormone synthesis. Okay, usually in the puberty or young adults. Yang ni 8 to 1. Okay. Again, goiter is very common in females, 8 to 1. Okay, nearly all long-standing simple goiters may transform into multinodular goiter. Mula-mula dia satu je, and then jadi multiple nodules, that is multinodular. So what happen when you have lack of iodine? You tak boleh nak synthesize T3 and T4. So your TSH will be increased. That's a compensatory mechanism. Okay. Still under diffuse. Okay, multinodular, similar, dia ada sporadic and endemic forms. Tapi multinodular ni usually in older age group. Okay, because They are late complications of or simple goiter. Apa problem with multinodular goiter ni? You tengok leher dia berombak-ombak the thyroid enlargement that cause cosmetic disfigurement, tak cantik lah. Okay, and there can be compression on the esophagus causing this dysphagia, and then also on the trachea it can cause stridor. Bila tarik nafas ada bunyi stridor. It can cause also compression on the SVC, superior vena cava obstruction or syndrome. And occasionally they have moderate hyperthyroidism, and that will lead to some cardiovascular manifestation. They have a lot of blood flow. You can listen for bruit in the neck. Dekat neck dia bila letak stethoscope dia ada because there is increased vasculation. Okay. So that's how multinodular goiter looks like. There's nodules. It can be area of calcification as well. And look at this. Look at the normal thyroid. Kecil je thyroid follicle. Look at the hyperplasia. Dah besar-besar, various sizes, small, big, and these are colloid inside the thyroid follicles. Okay. Yang ni is also a goiter. Yang ni we call it giant goiter. Ni besar ni, dalam 2-3 kilo dia kat leher je. Wow. Right? So this is still under diffuse goiter tadi. There can be hyperplastic stage, there can be colloid involution stage. Okay, in hyperplastic stage, there is modest enlargement and rarely exceeds 100 to 150 grams. And normally the punya size tu dia dua kanan kiri dia about symmetrical. That is in diffuse goiter. And histologically sama lah, you see colloid epithelium, small follicles is scanty colloid. Tapi in colloid involution there is marked enlargement of goiter, about 500 grams or more, setengah kilo atau lebih daripada setengah kilo dekat leher je. And there is gelatinous glistening cut surface. And you see large follicles macam gambar tadi large follicles distended with colloid, and because of the large follicles, the banyak colloid dia akan tekan the epithelium of the thyroid follicles jadi flatten the columnar epithelium. And in multinodular goiter, ni yang monstrous ni, MNG, we call it multinodular goiter. Dia enlargement can be up to 1 kilogram or more. Okay, heterogeneous multinodularity. There's islands of colloid-filled hyperplastic follicles. There can be irregular scarring or fibrosis. There can be hemorrhage too big sampai berdarah dalam tu. There can be hemosiderin deposition. There can be calcification, and there can also be cystic degeneration. Ada cystic changes dalam the thyroid gland. So kalau ada cystic changes, hemorrhage tu it can cause pain lah. Sometimes you can have pain. Okay, habis on the goiter. So it's just benign. Cuma it may cause problem. Okay. Right, now we go to thyroid tumors. Yang ni penting. Duduk penting. Okay, tapi this is more we have to remove it lah because it's cancerous. Okay, there are dua. Dia ada yang benign, dia ada yang malignant. The benign one is called adenoma. Malignant is carcinoma. Okay, most of solitary palpable thyroid nodules turn out to be dominant nodules within nodular goiter. Selalunya macam tiba-tiba ada satu ketul thyroid nodule. Selalunya ketul tu is actually part of a prominent nodule yang background dia memang ada goiter. Dia ada enlargement, tapi satu tu strikes out. Dia satu more prominent. That one. This is what I mean here. Most of the three palpable nodules turn out to be dominant nodules within a goiter. Sebenarnya goiter je. Okay. 80% of thyroid tumors are actually benign. They are adenomas. Okay. Solitary nodule is more likely to be neoplastic. Okay. Kalau yang lain tak bengkak, tiba satu je keluar. Yang tu selalunya tumor. Okay. Tapi kalau in general you pegang yang lain pun besar juga, ada satu yang prominent, that is goiter. Tapi satu dia je yang bengkak, that is usually tumors. And a functioning nodule, what we call it functioning nodule because they produce a lot of hormones. Bila kita buat thyroid scan, you see a warm or cold nodule. Warm nodule ni bila dalam scan tu dia macam dia macam apa nak cakap I don't know what radiologists call it. Dia lagi banyak dia punya cahaya tu. That's called a warm nodule. Kalau cold nodule tu dia tak strike out, doesn't flare up in the scan. And that is a cold nodule. Tapi cancer selalunya cold nodule. Kalau warm tu maknanya dia banyak hormon, so dia produce a lot of T3 and T4. And in younger patients less than 40 have greater likelihood of neoplasia. Kalau yang seketul tu tiba-tiba in young females, young patients less than 40 years old, selalunya is a tumor. Okay. And a nodule in male is more ominous than female, lagi bahaya. Kalau nampak nodule tu dalam male, kalau female biasalah it can be goiter. Okay. Kalau dalam male you suspect it's more likely to be a tumor. And how do you diagnose when you see a nodule in the neck? Is you do a fine needle aspiration cytology. FNAC, fine needles aspiration cytology. You put a needle with a syringe and you pull out some cells from the thyroid gland where the nodule is now. And then you smear on a slide and then send to the pathologist, and we will look under the microscope and tell you whether it's benign or malignant. You can say we see a lot of follicular cells, benign cells with colloid in the background, selalunya that is colloid goiter. Okay? Tapi kalau kita nampak dalam cells dalam slide tu ada banyak papillary structures, that can be papillary carcinoma or other types of cancer. Cancer can have different morphology. Alright. Okay, now we go to the benign tumors. Benign tumors are called adenoma. So, yang ada in the thyroid is called follicular adenoma. Why follicular? Because they arise from the thyroid follicular cells, the follicles of the cells. And they can also be benign tumors such as dermolysis, lipoma, hemangioma can also happen or occur in the thyroid gland. Yang ni yang penting yang malignant tumor ni, 4 ni. Papillary CA, follicular CA, medullary thyroid CA, anaplastic CA. If I don't ask now in the CA, in the continuous assessment, I'm going to ask in the final exam. Definitely. Malignant tumors of the thyroid. Tanda situ siap-siap. Yang paling common, papillary carcinoma. Young ladies like you, 20, 40, that's the age. Sebab thyroid ni dia suka, yang papillary ni lah, dia suka orang muda. Perempuan muda. Okay, so raba-raba your neck, ada tak? Solitary nodule. Kalau ada, pergi check buat FNAC. Buat FNAC, cucuk 1-2 kali, aspirate, the surgeon will do it. No, my MO also can do it. Okay, and then we smear on the slide and we look under the microscope. Nampak papillary structures, nampak nuclear inclusions, nampak grooving, that is papillary carcinoma. Okay, so always feel your neck, your breast, make sure you mandi, you rasa. There is early detection of cancer. Early detection, it is treatable. Tapi late detection, that's when problems come. Okay. So commoners, more than 85% are papillary carcinoma. Follicular, 5 to 15%. Medullary, yang dua last ni, 2, 3, 4 ni lah, is orang tua sikit lah. Okay, medullary dalam 60s, 50s 5%, nasib baik sikit je. Anaplastic less than 5%, siapa ni kejap Selamat datang. The scammers, shouldn't have answered. Okay, so all are cancers. Commonest papillary, follicular, second commonest, medullary 5%, anaplastic nasib baik rare. And it is very aggressive, nasib baik dia rare. Dia sangat jahat. 1 month meninggal. Okay, 1 to 3 months selalunya the prognosis is very bad. And lymphomas can also occur in the thyroid. Seperti tidur tu, kecil tu. Why lying down like that? Yeah, Lymphomas and mesenchymal sarcomas can occur in the thyroid gland, also rare. Okay, go to benign first, follicular adenoma. Okay, adenoma is a discrete, dia satu je, betul je. It's a solitary mass derived from follicular epithelium. When it's big, it can cause pressure symptoms, and sudden enlargement can cause bleeding inside the mass, in traditional hemorrhage, and it can cause, rarely can cause hyperthyroidism, and there's small to negligible risk of malignant transformation into cancer. It can transform, but very rare. Okay, excellent prognosis, but they're benign. Just take it out, then patient's cured. Okay, there's no prognosis, it does not recur. Okay. Alright, how does it look like? Macam ni. Ni thyroid gland. This is what I mean by meaty surface, yang dalam Graves tadi ada lebih kurang macam ni lah. That is an adenoma. Kenapa kita panggil adenoma? Dia well circumscribed. Dia ada capsule keliling dia. It's well circumscribed. It's got fibrous capsule. It is solitary. The adenoma, the benign. Okay, it's up to 10 cm in diameter. Average is about 3 cm. And it's solitary. When you cut it, it's tan to grey in color. It's soft and fleshy. It is encapsulated. There can be softening or hemorrhage inside here. It's a bit of hemorrhage there. They can have central fibrosis in larger tumor. They can also have calcification, and rarely they can have extensive necrosis. Bila dia terlalu besar, yang kat tengah tu tak cukup blood supply. Okay, if tak cukup blood supply, dia akan jadi necrosis, or it can be bleeding. Bila bleeding tu sometimes can cause pain a bit lah. There can also be cystic degeneration inside the thyroid follicles. Okay, histologically is encapsulated. These are the thyroid follicles. You see the colloid. Kat sini nampak tak? Dia tak ada scalloping macam tadi, macam Graves tadi. Graves tadi dia guna the colloid nak buat T3, T4 kan. That's why dia hyperthyroid. Kat sini, the colloid is pink, nice. There's ada lah satu dua lubang ni, but there is no scalloping yang macam lubang-lubang macam dekat dalam Graves tadi. Okay, so they are not there is no scalloping of the colloid. So there is a homogeneous architecture within capsule that differ from that outside the capsule. Okay, you can see a circumscribed lesion, and the growth is expansile. It can compress the surrounding non-oblastic thyroid tissue. And there can be a few patterns, fetal, embryonal, simple, colloid pattern, a mixed pattern. This one is under the microscope. Ultimately, same clinical or biological significance, little variation in cell and morphology. There's no nucleatypia. Maknanya nucleus cantik, dia bulat, dia tak ada nuclear polymorphism, tak ada polymorphism, because it's just an adenoma. It's a benign tumor. Ada a few other adenoma. There's Hurtle cell adenoma, spindle cell adenoma, tapi dia pun benign juga lah. This is from the thyroid follicles. Okay, this one is the important part. The thyroid cancer. It's, thank God, it's uncommon, but we see dia and dia juga lah. I mean, it's quite often juga we see it in the rat. It comprises about 1.5% of all cancers. Most are derived from the thyroid follicular epithelium. It's from the follicles in the epithelium itself, except medullary carcinoma. Ini pun favorite MCQ question. Okay, semua thyroid cancers are from the follicular epithelium, kecuali medullary. Medullary we go into that later. Okay, and there are certain genes involved in the pathogenesis of thyroid cancers. We'll go to that later. Okay, what causes thyroid cancer? Number one, radiation. There's irradiation during the first 2 decades of life. Maybe sebelum tu dia ada apa-apa disease ke apa that patient terima radiation to the neck, and that radiation can cause development of thyroid cancer. Okay, or certain thyroid disease macam tadi Hashimoto, multinodular goiter, toxic goiter tadi, can also turn into thyroid cancer. Genetic alteration, activation of PTC oncogenes, that one you see in 20 to 30% of papillary thyroid cancer, and red proto-oncogene in medullary carcinoma, also in pheochromocytoma, in familial men 2A. Yang tu kena baca maybe boleh juga tanya dalam MCQ, what are the genes involved in different types of cancer. Okay, we go here. Look here. These are the genetic alterations. There are two oncogenic pathways. One is the MAP pathway, or the mitogen activated protein kinase, and this is the MAP pathway. This one is the PI3K pathway. There's gain of function mutations along the components of this pathway, and there is pathway activation. This is what we call the carcinogenesis. Okay, in PTC, papillary thyroid carcinoma, there is red oncogene. There is mutation of the red oncogene. And from red, dia akan jadi RAS, stimulate RAS punya oncogene, and RAS selalunya mutation occurs in follicular and also in anaplastic carcinoma. The mutation of this gene occurs in these two types of thyroid cancer. Okay, BRAF pun dia ada BRAF mutation also occur in papillary carcinoma. Okay, PI3K, dia occurs in follicular and anaplastic carcinoma. There's PTEN oncogene juga also occur in follicular and anaplastic. Then there ada MEK1, and then all this dia ada dua cabang punya oncogenes which can cause different type of cancer, follicular carcinoma, and all this will cause increased cell growth and proliferation and turning the cells into cancer cells. Okay, ni cuba tahu sikit-sikit lah you have to know. At least papillary, you know red genes in papillary, RAS in follicular or anaplastic. Alright. Okay, we go to the commonest thyroid cancer. Ladies, remember, 2 to 3 to 1, 30 to 50, but I've seen younger than that. 20s, 18 pun dah ada thyroid cancer. Okay? Remember, the papillary ada 2 L. Papillary ada 2 L kan? So, dia spread via the lymphatic. Cara nak ingat dia ada 2 L tu. Okay? It has propensity for invading the lymphatics. Kalau follicular carcinoma, dia ada O. O dia spread via the blood. Blood ada O kan? Remember that. So papillary spread via the lymphatic, follicular carcinoma via the bloodstream. That's how it spreads. So papillary ni dia senang je, dia akan pergi dekat lymph nodes sebab dia masuk dalam lymphatic. Dia akan pergi dekat cervical lymph node. So you might come with cervical lymph node enlargement. Kadang tak nampak pun the necknya thyroid cancer enlargement. You know, perasan cervical lymph node enlargement dulu. Okay? But the prognosis is excellent. 90% survive for 20 years. Very good prognosis. Especially kalau you're young, less than 20 years old, lagi bagus punya prognosis. And the tumor is confined to the thyroid and is well differentiated. And it involves the activation of the MAP kinase pathway. The red oncogene tadi kan. Okay. Kalau the tumor is less than 1 cm, we call it occult papillary carcinoma. It's reported in about 1/3 of routine postmortem. When we do postmortem, bukan patient lah, orang tu meninggal ke apa, tiba-tiba bila kita dissect the neck, we found one small papillary thyroid carcinoma, less than 1 cm. That is called occult papillary carcinoma. Okay, who gets PTC is those who had ionizing radiation before the age of 20 for tonsillitis ke, acne ke, tinea capitis ke, dia ada tinea is what? Apa yang tinea? Panau dekat kepala, or dia ada enlarged thymus ke, that they have been radiated. Because of that, then they develop thyroid cancer. As a result of post-Chernobyl, particularly in children or after exposure to nuclear explosions at Marshall Islands. Okay, post-radiation juga, or following Hashimoto thyroiditis, and also in this syndrome, familial adenomatous polyposis can also have thyroid cancer develop later, and is familial in about 4.5%, it's genetic, and similar prognosis as sporadic disease. Alright. Papillary carcinoma. That's the tumor. Okay, that's a tumor. It is grayish in color, and there are areas of yellowish area here. There's a bit of hemorrhage there. Okay, so it can be infiltrative. It is not encapsulated. Tapi yang ni macam ada capsule sikit. Okay, tapi usually it's not encapsulated. They can have a cystic change, macam cyst kat dalam tu. They can also have foci of calcification. Okay, yang ni I akan describe dekat gambar. Mana gambar dia? Okay. You see these are the papillae. Papillae ni dia macam ada stalk kat tengah, dia ada macam tu that's the papillae. Bukan nama dia papillary kan? Capillary, so that's the papillae. And these are the follicular cells lining the papillae. Nampak tak ada dia nuclear? Nucleus dia clear. This is what we call often any nuclei. Macam mata anak patung tu, that's often any nuclei, meaning clearing of the nucleus. And dia ada ni, dia ada intranuclear inclusion. Dalam nucleus tu ada bulat tu. Bulat tu daripada mana? Daripada cytoplasmic dia masuk dalam nucleus, dia dipotong sel tu nampak macam ada bulat dalam tu. That's what we call intranuclear cytoplasmic inclusion. I want to show another feature, which is nuclear grooving. So, bila ada papillary formation, nampak tak yang gelap ni, yang merah ni? That is a type of calcification. It's called samoma body. Okay, 3 features of papillary carcinoma kena tengok dalam nucleus dia. One is often any nuclei ni, yang clearing ni. Number 2 ada nuclear grooving. Number 3 ada intranuclear pseudo inclusions. Okay, number 4 ni ada dalam tadi samoma bodies, ada juga satunya ada. Okay, so kejap mana grooving? Tak nampak grooving Dia macam coffee bean tau. The nucleus tu hujung macam tu, kat tengah ada line. Macam coffee bean terbelah kat tengah. That is what we call intranuclear nuclear grooving. Okay? Tapi dia tak semestinya ada form papillomated structures. There is a variant where it forms follicles bulat-bulat. Dia tak ada papillary langsung. Tapi nukleus dia cukup 3 tu. 3 nuclear features ni cukup. Walaupun dia not arranged in papillary structures, you still call it papillary carcinoma. Faham? So I might ask you name 3 features of the PTC. So kena tahu. One is nuclear grooving, nuclear, often any nuclei. Number 2 is intranuclear inclusions. 3 tu. Jumpa 3 tu PTC dah tu. No matter dia bentuk papillae ke, dia bentuk follicles ke. Okay, these are the variants follicular variant, tall cell variant tak ada gambar grooving Nanti you Google macam mana rupa grooving tu, macam coffee bean. Macam biji kopi yang terbelah 2. Ada line di tengah Okay, that is PTC very common in young females. So, jaga-jaga. Rubber. Your next. Okay, follicular carcinoma. This one is elder age group, 15 to 16 decades of life. Older age than papillary, rare in children, again female, 3 to 1. Okay. This one is slowly enlarging painless thyroid nodule, and dia tak masuk lymphatic, tapi dia terus masuk blood. Sebab dia ada O kan? Dia terus masuk blood pergi mana? Bone, liver, lung. They metastasize very fast. Okay? And the prognosis is poorer than papillary carcinoma. Okay, 1/3 to half of the patient harvest mutation in the PI3K, AKT signaling pathway yang pathway yang tunjuk tadi Alright. Follicular carcinoma, that's a tumor. Lebih kurang juga rupa dia macam PTC tadi. It's not encapsulated, greyish mass with yellowish areas, with areas of hemorrhage, and it's not encapsulated. Okay. From the name is follicle. So dia bentuk follicle kecil-kecil ni. It's micro follicles Yang pink the choroid okay. And the follicles are lined by cuboidal cells, follicular cells Alright. So histologically, there is microfollicle, follicular architecture with uniform cuboidal cells lining the follicles. Tapi nak diagnose follicular carcinoma, dia kena ada capsular or vascular invasion. Sebab kalau tengok macam ni je, tak tengok the capsule, kita tak tahu ni follicular adenoma ke follicular carcinoma. Sebab follicle dia sama, cantik je, it's uniform. Okay? So you have to sample the whole capsule. Keliling ni, sample keliling ni. Tengok dia dah menembus capsule of the thyroid or not. Kalau dia dah ada capsular invasion, dah tembus keluar, that is what we call capsular invasion. It's already carcinoma. It's no more adenoma. Faham? So capsular atau tengok dalam mikroskop, cari blood vessels. Ada tak thyroid cancer cells, follicles ni ada dalam blood vessels? That's what we call vascular invasion. So salah satu, ada capsular invasion pun dah carcinoma, ada vascular invasion pun dah carcinoma, either one. So we have to look for that. Okay? Kalau nicely encapsulated, no capsular invasion, no vascular invasion, there is a follicular adenoma. Okay, and then look at the nucleus. Dia tak ada nuclear features of PTC tadi, papillary thyroid carcinoma tadi. Dia tak ada nuclear grooving, dia tak ada often any nuclei, dia tak ada nuclear pseudo inclusion. Sebab remember PTC boleh juga bentuk follicles, tapi dia ada nuclear features 3 tu. Tapi kalau you tengok follicles ni banyak, tapi nucleus dia tak rupa nucleus PTC, you still call it follicular carcinoma, provided dia ada capsular dengan vascular invasion lah. Faham? Alright, next. Okay, yang ni tengok ni is microfollicles, tapi ada area of necrosis. Selalunya necrosis selalunya cancer lah. It's no more adenoma, tapi adenoma kalau besar sangat boleh ada necrosis lah. Okay, that is follicular CA. Now we go to the more aggressive thyroid cancer, anaplastic carcinoma and medullary carcinoma. Okay. Anaplastic dengan medullary ni is under undifferentiated. Ini dia tak rupa mak dia pun, dia dah lain dah rupa dia. It's undifferentiated cancer. It's highly aggressive thyroid malignancy composed of undifferentiated follicular thyroid cells. Anaplastic masih from the follicles. Medullary je tak. Medullary daripada sel lain. Okay. It's elderly individuals, dah tua dah, 50, 60, 70 macam tu. Especially in endemic goitrous region. Sama juga kat Mongolia, atas gunung sana, they can have anaplastic carcinoma. But sporadic one you can see in Malaysia pun ada juga yang ada anaplastic carcinoma, tapi it's rare lah. Okay. My friend punya father itu pass away because of anaplastic carcinoma 1 month je. 1 month besar, meninggal. 1 month dia punya enlargement tu, very acute. Okay, it can arise de novo and more commonly by de-differentiated or well-differentiated. Dia boleh terus jadi anaplastic carcinoma, that's what we call de novo. Dia terus jadi that cancer. Or it can differentiate. Mula-mula dia ada papillary. Papillary tu yang bertukar jadi anaplastic. Ada 2 cara. Ataupun dia terus jadi anaplastic. That's what we call arise de novo. Or from papillary or from follicular carcinoma. And it involves the RAS or PIK3CA mutations. It's rapidly enlarging bulky neck mass invading the structures, causing hoarseness of voice, dysphagia, dyspnea, difficulty in breathing, difficulty in swallowing, dysphagia, difficulty in swallowing. It metastasizes YE. Why? Dia aggressive, dia cepat masuk blood vessels, dia metastasize all over, liver, lungs, brain, semua. There's high mortality due to local invasion. Only survive for mean is about 4 months. Median age of survival, bukan age, median time to survive is about only 4 months. That's the whole tumor there. Solid tumor, grayish in color, areas of hemorrhage, irregular, non-encapsulated. When I ask you to describe whatever you can. Because if you don't describe a lot, you're going to lose marks. Okay? Katakan anda letak 2 markah ke 3 markah ke, kadang-kadang 2 markah tu 4 points saya nak. Half mark. Okay? So put put more, don't put less. Alright. This is anaplastic carcinoma. Tak ada rupa thyroid follicles lah. It's composed of spindle-shaped cells, ada a lot of giant cells, dah tak ada follicle macam follicular carcinoma tadi. This is dark malignant cells and small cell type. These are the histological type, spindle cell CA, giant cell CA, small cell carcinoma. So this is anaplastic carcinoma. Next we go to another aggressive thyroid cancer, tapi it's not arising from the follicles, which is medullary carcinoma. Where is it from? It's from the C cells. C cells is a neuroendocrine tumor, okay, neuroendocrine cells in the thyroid. It's from the parafollicular C cells. In between the follicles, ada cells kat celah-celah tu, nama dia C cells. Or it's a type of neuroendocrine cells. So medullary carcinoma originates from these cells. It's not from the thyroid follicles tadi, and cuboidal tadi. Alright. So the C cells are multibranchial body of neural crest. It can secrete calcitonin. So in medullary carcinoma, you check the blood for calcitonin levels, but they secrete calcitonin, a type of hormone secreted by C cells. Okay, and it can also elaborate a variety of other stuff, such as prostaglandin, serotonin, CEA, CTH, this cell yang C cells. Thank God, it's only about 1 to 2% of thyroid carcinoma. It's very ganas. It can also occur sporadically, or it can be familial. Men, they're associated with MEN type 2A or type 2B syndromes. So, the familial medullary thyroid carcinoma syndrome, also von Hippel-Lindau disease or neurofibromatosis, is related to that. 70% are sporadic, age 40 to 60, it is solitary mass, and 30% are familial. Usually yang familial ni younger patients. Yang ada syndrome ni, yang ada MEN 2A, 2B ni usually are younger patients, such as around 35 macam tu, mean age about 35. It's caused by gain of function, germline mutations in the red gene, also ada gene mutation. It's usually bilateral, multicentric with C cell hyperplasia. Mula-mula dia become hyperplasia, lepas tu jadi cancer, C cell. It's usually discovered by screening test for serum calcitonin, okay, and you do also a red oncogene mutational analysis. Alright, that's medullary carcinoma. It's solid, yellowish in color, ada hemorrhage sikit-sikit, and apa yang penting kat sini, gambar ni, microscopically, nampak tak that pink mass in between the malignant cells? What are these? It produce apa? Ni, amyloid. The only one and only thyroid cancer that produce amyloid is medullary carcinoma. Favorite MCQ. Okay, and it's from the C cells, kan? The cancer is from C cells. They're not from follicular cells. It can be broad bands of polypolar amyloid stroma. There's nests of polygonal to spindle-shaped cells. These are the blue ones are the malignant cells, and they secrete this amyloid. And under electron microscopy, EM is electron microscopy, there's secretory granules in this tumor. Tak ada gambar pula. Okay, macam mana nak tahu yang pink tadi amyloid, bukan colloid? Kan? Ni colloid, ni normal colloid with normal thyroid follicles. Tiba-tiba yang ni diffuse tumor cells. You see this pink stuff. So macam mana? Dia sama yang ni pink, yang colloid pun pink. So you do a Congo red stain, nampak merah. With Congo red, amyloid will look red in color. So you do a Congo red stain to confirm it is amyloid. Okay, pun favorite MCQ juga. Congo red stains amyloid in medullary carcinoma. Okay, finish on thyroid. Now we go to 1 hour already. We go to parathyroid. Parathyroid ada adenoma dan hyperplasia. They can also have carcinoma. 3 benda. Sama juga macam thyroid itu. Dia ada hyperplasia, which is your graves. You have the goiter, also part of hyperplasia. You have follicular adenoma. Then you have carcinoma. Yes? Pardon? 2 minute break. Okay, go. Alright. 2 minutes to the toilet. Any questions? It's a long lecture. Endocrine tak cukup. Dah suruh you baca sendiri lah.
Tengok tu Facebook. Kejap kau. Kau sabar. Lagak. Sabar. Boleh lah main sekali.